Welcome to the deep dive. Today we are taking on a huge high stakes area of nursing. Pediatric musculoskeletal health.
Hmm.
And look, we're going to forget the long chapters, the dense lecture notes. Our goal here is to be your expert guides, cutting straight to the clinical core.
Right.
We're talking about the facts, the red flags, and the priority nursing actions you really need to walk away with, especially for those high stakes exams.
This is such a critical field because, as nurses, we have to start with this one fundamental idea.
Hmm.
Children are not just miniature adults.
Not at all.
Their musculoskeletal system is fundamentally different. I mean, for instance, their bones are way more porous, more pliable.
Which is why they get those very specific fractures, like green stick and buckle fractures.
Exactly. And their long bones are growing entirely from the epiphyseal plates, the growth plates.
Yeah.
And those stay open until their late adolescence.
That makes the stakes incredibly high, right? Because any injury to that growth plate, to the physis, could mess up all future bone growth.
Precisely. And while, their fractures do heal faster, the risk of a long-term developmental problem is significant. We are really focused today on delivering knowledge that is immediately applicable right at the bedside.
Okay, so let's unpack this. We've organized it into four powerful, logic-driven clusters. I think this will really help with learning retention.
Okay.
First, we're going to tackle lower extremity structural deformities, so things like DDH and clubfoot that we see really early on. Second, we'll move to hip conditions of the growing child. This is more about vascular or growth plate issues that pop up later, like LCPD and SCFE. Third, we're going to look at the chronic and systemic conditions, so DMD, scoliosis, and osteogenesis imperfecta, or OI.
Big ones.
And finally, the emergent stuff, acute trauma, immobilization, and safety. We'll cover fractures, casts, traction, and maybe most critically, compartment syndrome.
And for every single one of these clusters, we are going to hit those high-yield pillars that define priority nursing care. So we'll talk about the mechanism and pathophysiology, the hallmark symptoms you can't miss, the management, both farm and non-farm,
Okay.
the essential priority nursing actions, and, critically, the red flags and those NCLEX traps that often trip people up.
All right, let's start with cluster one. Structural deformities. These are mostly related to, intrauterine positioning or early developmental issues with the feet and hips.
Exactly. The unifying idea here is kind of twofold. First, you have to identify and treat these conditions immediately after birth because the baby's structures are still so malleable.
Makes sense.
Second, the management relies heavily on non-operative techniques. We're talking serial casting, bracing, harnessing.
So for the nurse, what's the focus?
The focus shifts immediately to meticulous parent teaching and managing the number one risk, which is skin integrity.
Skin breakdown.
Always. Compliance is key, of course, but skin breakdown is the fastest way to completely derail the treatment plan.
Okay, let's start at the foot then, with metatarsus adductus, or in-toeing. How is this different from something more severe like clubfoot?
Metatarsus adductus is much less severe. It's mainly a forefoot issue. The forefoot just turns inward, which gives the side of the foot this convex, curved look.
And it's usually from being cramped in the womb.
Often, yeah. It's linked to intrauterine positioning or genetic factors. Clinically, we spend a lot of time reassuring parents because it's generally a benign, correctable condition. The management is way less aggressive than for clubfoot.
So what does that look like?
It usually starts with just stretching exercises prescribed by a therapist. Only in the really rigid, non-flexible cases do we have to resort to some short-term casting.
Okay. So then if a nurse sees a deformity that seems much more complex, much more rigid, they should be thinking clubfoot.
Immediately.
Yeah.
Talipes equinovarus, or clubfoot, is dramatically more intricate. It involves not just the forefoot, but the ankle and the heel, too.
It's a through-part deformity, right?
Right. The foot is in quinus, so it's plantar flexed, pointing down. It's in varus, meaning the heel turns inward. And it's in adductus, so the forefoot turns in.
And the cause.
It's mixed. It could be positional, neuromuscular, vascular, or genetic. It's complex. Boys are affected at double the rate of girls, and it's bilateral in about half of all cases.
I remember there's a connection to other issues, too.
Yes, that's a high-yield fact.
Yeah.
Clubfoot often runs parallel with other neurological issues like spina bifida, arthrogryposis, and cerebral palsy.
And what is the absolute key clinical fact about the management timeline?
Treatment must begin immediately.
Okay.
Ideally within the first week of life. It requires manipulation and serial casting, a new cast, every single week.
Wow. Weekly.
Yeah. If it's left untreated, The muscle and tendon shortening just becomes rigid, and that leads to a permanent disability.
So the big challenge for parents is that this isn't a quick fix.
Not at all. The process takes many, many months. It often requires a small surgery later, a heel cord tenotomy, and there's a pretty significant risk of relapse as the child grows.
Okay, moving up to the hips. Let's hit one of the most tested conditions. Developmental dysplasia of the hip, or DDH.
DDH is just this abnormal development of the hip joint. It can range from a shallow socket, the acetabulum, all the way to a full dislocation.
There's a mnemonic for the risk factors, isn't there?
Yes, and you need to know it. The 4 Fs. Female, because of increased joint laxity. Firstborn, feet first, which means breech presentation and a strong family history.
So it's a mix of mechanics and physiology.
Exactly. The mechanical forces of a breech birth, combined with things like maternal hormones, cause that joint instability.
And the signs change drastically as the child gets older. So what are the priority assessments for an infant who isn't walking yet?
In an infant, you're looking for signs of instability. A shortened limb on the affected side is a big one. But crucially, the nurse has to assess for restricted abduction.
Meaning the hip won't move outward.
Right, it won't move out as far as the unaffected side. We also look for physical signs. Like when the baby is lying on their stomach, you check for unequal gluteal and thigh fat folds.
And the classic physical exam tests?
The gold standard physical exams are the Barlow test, where you can feel the femur slide out of the socket, and the Ortolani test, which is that palpable, sometimes you can even hear it clunk as the hip is reduced back into place.
And then once that child starts walking, the signs completely shift.
They shift from instability to functional deficits, exactly. Once they start bearing weight, maybe around 18 months or older, we look for the Trendelenburg sign.
The pelvic tilt.
Yes, the pelvic tilt. When the child stands on the affected leg, the pelvis actually drops on the unaffected side. You'll also see a shortening of the leg, a compensatory lordosis or sway back, and if it's bilateral, a really noticeable waddling gait.
How do you confirm the diagnosis?
It depends on age. We rely on ultrasound from birth up to about 4 months because the femoral head is still cartilage. After 4 months, when it starts to ossify, we switch to X-ray.
Before we move on, a quick note on genuvarum, or bull legs, and genuvalgum, knock knees.
Sure, these are really common deviations of the leg axis. Varum is that outward bowing, like a cowboy stance, and valgum is when the knees knock together.
And the key thing here is reassurance, right?
Most of the time, yes. We often reassure parents that these conditions usually resolve spontaneously as the child's weight-bearing changes and the growth plates remodel. Severe cases might need bracing, but for nurses, the core job is education and making sure they're following the plan.
Okay, let's talk about the traps. Specifically around these non-operative treatments, a lot of it comes down to compliance and skin safety.
It really does. The clubfoot trap, for instance, consistently tests your knowledge of the length of treatment.
So you're saying don't pick the easy answer.
Never choose an answer that implies a single cast or a quick surgery is going to fix it. Management is serial casting. It's a long, arduous commitment. When you're teaching the family, you have to reinforce the need for weekly cast changes, not just a one-time thing.
And for DDH infant assessment, what are the most common distractors you see?
The classic finding is limited abduction, not limited induction. That's a big one.
Okay.
Distractors might also include things like pain on passive movement, but instability in an infant doesn't always equal pain.
So what are the keys?
Hallmark signs are your keys. Asymmetry of the thigh fat folds and that telescoping or piston mobility of the thigh. And always remember, the Trendelenburg sign belongs to the older walking child, not the infant.
Got it. Now, when any external device is applied, a cast, a brace, a harness, what is the absolute clinical priority that trumps everything else?
The ultimate priority, and it outweighs mobility issues initially, is the potential for skin breakdown.
Always.
Always. If the skin is compromised, the whole treatment plan is in jeopardy. And this leads directly to critical teaching for the Pavlik harness.
And the rule is, parents don't adjust it.
The only people who can adjust the harness straps are the practitioners. The fit has to be absolutely precise to keep the hip in the right position. Parents have to perform frequent, meticulous checks 2 to 3 times a day, looking under every single strap for redness or irritation.
And what are the classic mistakes parents make that we have to educate them against?
Lotions, creams, and powders, they are the enemy.
Right.
You must avoid applying them under the harness or brace. They just clump up, they retain moisture, and they dramatically increase friction, which is what causes the breakdown.
What about diapers?
The teaching has to be crystal clear.
Yeah.
The diaper goes under the harness. This is to maintain skin hygiene and reduce the risk of contamination.
And what about swaddling?
We discourage any swaddling that keeps the infant's legs rigidly extended and adducted. We want the hips in that hip-healthy frog leg position of abduction and flexion.
Okay, let's talk management for these. For foot deformities like metatarsus adductus and clubfoot, it's almost all non-pharmacological, right?
Yes, it's dominant. For
Mhm.
metatarsus adductus, it's stretching. For clubfoot, it's serial casting. Surgery, like a tenotomy, is really a last resort.
So nursing care around the cast is key.
It's vital. The teaching has to cover keeping the cast dry, monitoring for any foul odors that could signal an infection, and teaching parents to do neurovascular checks and watch for any swelling or compromised circulation.
DDH management is a timeline. It's all based on growth. Can you detail that progression for us?
Absolutely. For a newborn up to about 6 months, the Pavlik harness is the primary non-invasive intervention.
And the goal there.
The goal is to keep the hip in that optimal position of flexion and abduction. You want the femoral head to press into the acetabulum to deepen the socket.
But what if DDH is caught later?
If it's caught between 6 and 18 months, the treatment becomes much more invasive. It often starts with traction to loosen the tissues, followed by a reduction, either closed or open, and then immobilization in a large spica cast.
And for an older child?
After 4 years of age, repair is exceedingly difficult because of fixed deformities. It often requires an operative reduction and an osteotomy, which is a major bone-cutting procedure.
Let's pull out the essential generalized brace care. This applies to a lot of conditions, not just DDH.
This is non-negotiable standard of care. The child must wear a clean, white, wrinkle-free lining, like a cotton undershirt or a sock beneath the brace.
Why is that so important?
It absorbs sweat and, crucially, prevents wrinkles from creating pressure points.
And you have to start slow.
You must start slowly, 1 to 2 hours at first, then progressing to 2 to 4 hours, just to give the skin time to adapt. And skin checks must be frequent, initially every 1 to 2 hours, then every 4 hours once the skin is stable.
What's the red flag with redness?
If you see persistent redness that lasts longer than 30 minutes after you take the brace off, the brace must be left off until the skin clears entirely, period.
And you mentioned something about toughening the skin.
Yeah, to toughen the sensitive areas where pressure is applied, we teach parents to use alcohol wipes 3 to 4 times a day. The alcohol dries and hardens the epidermis, which increases its resistance to friction and breakdown.
Okay, let's do a quick recap of cluster 1. The mechanism is congenital or positioning related.
Right. Hallmarks are those asymmetrical gluteal folds and limited abduction in DDH, and the complex 3-plane foot deformity in clubfoot.
Red flags.
Persistent redness under any device that requires immediate action, or signs of DDH instability which demand the Pavlik harness.
And priority actions.
Skin integrity, teaching compliance for that long-term correction, and making sure that early casting or harnessing happens.
Finally, the key NCLEX traps to avoid.
Assuming clubfoot is fixed by one cast, applying lotions or powders under any brace, and forgetting that DDH requires both flexion and abduction.
All right, moving on to cluster 2. Hip conditions. These involve a compromise to the femoral head structure or its blood supply, and they present with a classic chief complaint, a limp and pain, mostly in older kids and adolescents.
Exactly. The unifying idea here is that the two major conditions, LCPD and SCFE, they present in a really similar way. Limp referred pain.
But they're radically different.
Radically different in mechanism and, more importantly, in urgency. Both are orthopedic emergencies in the sense that they require non-weight-bearing status immediately to prevent long-term damage. But SCFE demands urgent surgery. We have to be able to tell them apart, and fast.
Okay, let's start with Legg-Calvé-Perthes disease, or LCPD. The core problem here is a vascular compromise, right?
Exactly. LCPD is a vascular necrosis cell death of the femoral head. It's idiopathic and it's generally self-limiting, which means the body will eventually revascularize and remodel the bone over time.
But that process is slow.
Very slow. It's most common in boys, usually between 4 and 8 years old, though we can see it up to age 12. The disturbed circulation is what leads to that ischemic aseptic necrosis of the femoral head.
So what should a nurse look for in the history? What are the parents going to report?
They'll often report a long history of a sort of insidious, slow-onset limp, soreness, stiffness, or limited range of motion. The pain is typically worse in the morning or after a long day of activity.
And sometimes there's no pain at all.
Interestingly, yes. Some children present with a completely painless limp, which is a classic finding. We also might see they have a delayed bone age. And on assessment, you'll look for signs of muscle weakness and atrophy in the thigh from disuse.
And the management. If it's self-limiting, how do we actually intervene?
The crucial goal is containment. That's the word to remember. We have to keep that fragile necrotic femoral head contained snugly within the acetabulum while it revascularizes and heals.
How do you do that?
It requires strict rest, initial non-weight bearing, often with crutches, and potentially bracing to maintain abduction. Physical therapy is often initiated to preserve range of motion.
What about exercise?
Low-impact activities are key. We often recommend swimming because it allows for muscle activity without compromising the hip joint with weight bearing. And you have to prepare the family for the reality of it. The whole disease process lasts about 18 months to several years.
Okay, now for the true emergency. Slipped capital femoral epiphysis, SCFE. This is a structural failure of the growth plate.
SCFE is a pediatric orthopedic emergency, full stop. It's a spontaneous displacement or slip of the proximal femoral epiphysis in a posterior and inferior direction.
So the head of the femur is literally slipping off the neck.
At the growth plate, yes, it's slipping off. This typically affects older, pre- or early adolescent boys, aged 8 to 15, and the biggest risk factor is obesity.
Why obesity?
It's the increased shear stress on that growth plate during a rapid growth spurt, especially with excess weight, that causes the slip. It can also be linked to endocrine issues like hypothyroidism.
The symptoms can sound similar to LCPD. How do we differentiate them clinically?
You have to look at the acuity and the nature of the pain. The child presents with a limp, but a very high yield finding is referred pain.
They don't complain about their hip.
Right, they might not complain of hip pain at all, but only pain in their groin, their thigh, or their knee.
The knee pain is a big one.
It's huge. On physical exam, you'll note a loss of hip flexion, abduction, and internal rotation. The affected leg often has what we call an obligate external rotation. When you try to flex the hip, the leg automatically rotates outward.
And what's the immediate red flag?
The immediate red flag that signals an unstable slip is the inability to bear any weight at all. That demands immediate action.
So why is this an immediate surgical emergency? What's the biggest risk?
The blood supply. The blood supply to the femoral head, the medial circumflex femoral artery, often runs right across that growth plate.
So when it slips?
When the femoral head slips, especially in an unstable slip, it can shear or compromise that artery, leading to a vascular necrosis. If we stabilize it quickly with surgery pinning, we preserve the blood supply. If we delay, the risk of AVN and the need for a future total hip replacement just skyrockets.
So non-weight bearing is mandatory.
Absolutely mandatory from the moment SCFE is even suspected.
The primary NCL-EX challenge here seems to be separating the management for LCPD and SCFE.
That's the core trap recognition. LCPD requires long-term restorative rest and bracing, potentially for up to 2 years.
And SCFE?
SCFE is an immediate surgical emergency. It requires urgent pinning to stabilize that growth plate. So that means immediate non-weight bearing and getting them ready for surgery.
And what about that referred pain you mentioned?
That is a massive NCL-EX priority. If a child in that 8 to 15 age range comes in with referred knee or thigh pain, you must always assess the hip to rule out SCFE or LCPD, even if the knee joint looks perfectly fine on exam.
Never assume the pain is where the problem is.
Never assume the pain is where the pathology lies in this age group.
And the duration trap for LCPD.
Yes, the management duration trap. It's critical. You cannot reassure parents that this will be a quick fix. You have to communicate that this will require approximately 2 years of careful management to allow for that revascularization and remodeling of the femoral head.
Okay, let's nail down the management. For LCPD, it's all about protection and containment.
Right. Strict rest, non-weight bearing with crutches, sometimes a brace like an Atlanta brace to keep the femoral head in the acetabulum. Those are the key non-pharm interventions. And we often use PT to help maintain abduction and muscle tone without the weight bearing.
For SCFE, the intervention is almost purely surgical.
Yes. Immediate non-weight bearing is the crucial pre-op nursing action. Surgery, typically in situ pinning, is the definitive treatment.
What about post-op teaching?
Post-op teaching involves strict adherence to whatever the new weight-bearing limits are. And we also have to educate the family that even a successful pinning carries the risk of limited range of motion and potential early arthritis later in life because the anatomy has been altered.
And can you just briefly touch on the use of traction?
Sure. For temporary immobilization or for managing contractures, we might use buck traction. It's a type of skin traction used for straight leg extension. And when you're managing a child in any traction, remember you also have to assess the uninvolved joints and muscles for tightness or contractures from the immobility.
Okay, summary for cluster 2. Mechanism. Vascular compromise in LCPD versus an actual growth plate slip in SCFE.
Exactly. Hallmarks. A persistent limp and pain, often referred to the knee or groin, coupled with limited hip ROM, especially abduction and internal rotation.
Red flags.
The sudden inability to bear weight, that signals an unstable SCFE slip. Also, severe pain.
And the priority action.
Mandatory immediate non-weight bearing and an urgent surgical referral for SCFE.
And finally, the NCLEX traps to avoid.
Mistaking the 2-year time frame for LCPD correction, or, and this is a big one, ignoring referred knee pain in an adolescent.
All right, our third cluster. This focuses on conditions that are progressive, systemic, or involve a major multiplanar deformity. These require really complex, long-term nursing care. It's much more than a single intervention.
Right. The unifying idea here is really the impact on development. These conditions, which are often genetic, lead to chronic instability, immobility, or profound physical changes that significantly impact the child's developmental progress, their self-image, and long-term quality of life.
So the nurse's role is much more about chronic disease management and safety planning.
Absolutely.
Let's start with scoliosis, the most common spinal deformity. This often requires a pretty significant intervention during adolescence.
It does. Scoliosis is a triplanar deformity. It involves a lateral curvature, significant spinal rotation, and a reduced thoracic kyphosis. 80% of cases are idiopathic, and it becomes most visible and progresses most rapidly during the pre-adolescent growth spurt.
That's the danger zone.
That's the period of peak height velocity where these curves can just worsen dramatically.
So what are the telltale symptoms we need to teach parents and school nurses to look for?
We're looking for asymmetry. The test for it is the Adams forward bend test.
And what are you looking for during that test?
Key findings include uneven shoulder height, a prominent scapula on one side, and most importantly, a one-sided rib hump. That's caused by the rotation of the spine. We also look for uneven hips.
And management is guided by the degree of the curve.
Exactly. Curves less than 25 degrees, we just observe and monitor. Curves between 25 and 45 degrees are treated with a rigid brace, like a Boston brace, often worn 18 to 23 hours a day, plus specialized exercises.
And what about the severe curves?
Curves 50 degrees or greater require surgical fusion. This is to prevent respiratory compromise and cardiac involvement later in life.
There's a crucial side note on congenital scoliosis, isn't there?
Yes. If the scoliosis is congenital, so it's present at birth, nurses have to understand the link to other system abnormalities. It's associated with GU abnormalities 30% of the time. So you need a renal ultrasound and spinal cord abnormalities 20% of the time. This multi-system approach is vital.
Okay, next. Duchenne muscular dystrophy, or DMD. This is a progressive, life-limiting, X-linked genetic disorder.
DMD is the most common and the most severe muscular dystrophy. It almost exclusively affects males. The onset of muscle weakness is typically between 3 and 7 years old.
And it's caused by a gene mutation.
Yes, a mutation in the gene that encodes for dystrophin, which is a crucial muscle protein. Early diagnosis relies on assessing creatine kinase levels. They're dramatically high in the first 2 years of life as muscle breaks down, and then they decrease later as muscle is replaced by fat and fibrosis.
What are the classic high-yield symptoms the nurse has to be able to spot?
The child might have delayed walking, often past 16 months. They have a progressive waddling gait, frequent falls, and difficulty running or climbing stairs.
And the Gower sign.
The Gower sign is pathognomonic. The child has to use their hands and arms to literally walk up their own legs to stand up from the floor.
Yeah.
That's because of their proximal muscle weakness.
And the other key sign.
Pseudohypertrophy of the calf muscles. They look really big and muscular, but it's a false appearance. It's caused by fatty infiltration, not actual strength.
The nursing role in DMD shifts pretty dramatically as the disease progresses.
It's a relentless progression. Children are typically in a wheelchair by 9 to 12 years old. Death usually occurs in the early 20s. Most often from respiratory or cardiac failure.
And there's no cure.
No cure. So the nursing goal is primary.
Yeah.
Maintain function and quality of life for as long as possible. This means ROM exercises to prevent contractures, bracing, and extensive teaching on respiratory management, including the eventual need for BiPAP at night, and ensuring proper nutrition as swallowing becomes difficult.
Finally, we need to address osteogenesis imperfecta, or OAI. Brittle bone disease.
OI is a genetic collagen defect. It leads to extremely fragile bones that fracture with minimal or even no trauma.
What are the hallmarks?
Frequent fractures, increased joint flexibility, short stature, weak muscles, thin, soft skin, and sometimes hearing loss.
So what's the top nursing priority for parent teaching?
Because repeated fractures are often the first diagnostic clue. The number one priority is teaching trunk and extremity support during everyday care.
So just basic handling.
Any handling diaper changes, moving the child, it has to be done with extreme gentleness. You use supporting sheets, you maintain alignment, you do anything to prevent an injury.
And a quick reminder on Marfan syndrome.
Marfan is another connective tissue disorder that affects multiple systems. You see the skeletal changes, like those long limbs, but the nursing focus has to be on the severe cardiac implications, especially aortic root dilation. That requires lifelong monitoring and often beta blockers.
Let's hit the DMD assessment trap related to physical appearance.
The DMD assessment trap relies on what you see. That pseudohypertrophy of the calves, it looks like strength, but it is pure fatty replacement and fibrosis. Always choose the option that reflects the underlying weakness, not muscle strength.
For scoliosis assessment, what about pain? Is that an early sign?
That's the scoliosis assessment trap. The assumption is that it's painful early on. Early idiopathic scoliosis typically does not cause pain or lordosis. The classic findings are strictly those asymmetries you see on the forward bend test, the rib hump, the uneven scapula, the shoulder and hip height difference.
Okay, but if that curve progresses and requires a spinal fusion, the post-op nursing priority becomes urgent and neurological.
Post-op spinal fusion is a major procedure. We require urgent monitoring for impaired color, sensitivity, and movement to the lower extremities.
Why is that so critical?
It's a potential neurovascular emergency. It could signal nerve root or spinal cord compromise from the surgery or from swelling. A finding like that demands immediate notification of the surgeon.
How do you manage the post-op period?
We manage pain aggressively, often with PCA pumps, and we encourage early ambulation. We often have the patient sitting up or walking within 24 hours. It's vital for recovery and preventing immobility complications.
What are some other common post-op management points to remember?
The patient might initially need a chest tube if it was a transthoracic approach and a urinary catheter for the first few days. And post-discharge teaching focuses on serious activity restrictions.
Like what?
No bending, twisting, or heavy lifting. No PE or sports for a minimum of 6 months to allow that fusion to solidify.
For scoliosis, bracing is the core non-farm intervention before surgery.
Right, and compliance is the biggest challenge. For adolescents who need to wear a brace for 18 to 23 hours a day, nurses have to be experts in providing psychological support and coping strategies. For surgical patients, it's all about pain management, skin care, and those neurovascular checks every 2 hours.
DMD has no cure, so nursing management is entirely about function and safety.
The non-farm interventions are about maintaining activity, preventing contractures with frequent ROM, and eventually managing respiratory decline. Because of their progressive immobility, we need exhaustive safety planning.
Give me some examples.
Ensuring safe transfers with lifting devices, modifying the home, and developing specific fire evacuation plans that account for their limited mobility and the potential need for oxygen safety.
And what about meds?
Corticosteroids, like prednisone, are often prescribed to try and slow the muscle degeneration.
And for OI, how do we actually teach that gentle care?
It's all hands-on demonstration. It means teaching parents to never pull or twist an extremity, to lift the baby using a support sheet, and to support the entire trunk and all the limbs at the same time when moving the child.
Okay, recapping cluster 3. The mechanism is primarily genetic for DMD and OI, or a complex growth deformity for scoliosis.
Hallmarks: Gower sign and pseudohypertrophy for DMD, the rib hump and asymmetry for scoliosis, and recurrent, frequent fractures for OI.
Red flags.
Post-op neurovascular changes after a spinal fusion, and any signs of respiratory decline in DMD.
And priority actions?
Safety and injury prevention for OI, functional maintenance for DMD, and vigilance for post-op complications.
And the NCLEX traps to avoid.
Confusing that pseudohypertrophy with actual strength or assuming that pain is an early symptom of scoliosis.
We've come to our final cluster: acute trauma, immobilization, and safety. This is where we focus heavily on immediate management, cast and traction care, and the absolute priority of avoiding complications.
The unifying idea here is that while pediatric fractures heal really fast, our unique challenges are in protecting that delicate growth plate, managing the consequences of immobilization, and recognizing and reacting to the high-stakes emergency that is compartment syndrome.
Let's review pediatric fractures and assessment. What makes them unique clinically?
Because pediatric bones are so pliable, they get types of fractures you don't see in adults. There's plastic deformation, where the bone just bows but doesn't break. There's buccal or torus fractures, which is a bulge on one side. and green stick fractures, an incomplete break, like a young tree branch.
And the highest clinical concern is always a fracture through the growth plate.
Always. A fracture that involves the growth plate, or physis, can severely affect future length and alignment.
So what's the initial immediate nursing assessment and intervention?
First, you need a thorough history. Does the story of the injury actually match the child's developmental level and the injury itself?
If not, you suspect abuse.
If the story's inconsistent, you have to suspect and report child abuse. You look for fractures in different stages of healing or bruising on a non-mobile infant.
And for management.
If a fracture is suspected, you have to immobilize the injury. Proper splinting means immobilizing the joint above and the joint below the suspected fracture site.
And for soft tissue injuries.
For sprains and strains, the initial priority is RICE. Rest, ice, which is the immediate priority to limit swelling compression, and elevation for the first 24 to 36 hours.
Immobility is often necessary for healing, but it comes with a terrible price. The widespread consequences of immobility.
This is a huge area of nursing intervention. Prolonged immobility affects every single body system.
Let's start with respiratory.
Respiratory, pore expansion, atelectasis, risk of pneumonia. Our intervention has to be proactive, teaching the use of an incentive spirometer and frequent physician changes.
Musculoskeletal.
We see rapid loss of strength, joint stiffness, contractures, and crucially, bone demineralization, which leads to osteoporosis and hypercalcemia. We see orthostatic intolerance and venostasis, which increases the risk of DVT or thrombus formation. We need TED hose and passive ROM.
And GI.
Decreased peristalsis leads to constipation. Nursing management requires an aggressive increase in fiber and fluid intake in their diet. And psychologically, kids often experience anger, frustration, and developmental regression. Cuddling, play therapy, and parental interaction are critical.
Okay, let's move to cast and traction management. What's the difference between fiberglass and plaster, and what are the essential rules for a new cast?
Fiberglass is lighter, stronger, and it dries fast 5 to 30 minutes. Plaster is heavier and cheaper, but it can take up to 48 hours to dry.
And the big rule about drying?
You must never try to speed the drying process with heat or fans. This can cause burns or uneven drying, which compromises the cast's integrity.
And when a cast is applied, nursing care immediately centers on vigilant neurovascular status. We need to explicitly state the 5 Ps.
Vigilance is mandatory. Frequent neurovascular assessment, the 5 Ps, must be done every 2 hours initially. We are checking 1. Pain. Is it severe and unrelieved?
2.
Pallor. Is the extremity pale or white? 3. Pulselessness. Is the pulse absent or weak?
4 and 5.
Paresthesia. Is there tingling or numbness? And 5. Paralysis. Is the patient unable to move the extremity?
What else?
We have to elevate the newly casted extremity, especially in the first 24 hours, to manage swelling. Repositioning every 2 to 3 hours. Use moleskin or padding to protect the skin from rough cast edges and reinforce the teaching. Never ever insert anything into the cast to scratch an itch.
How do those priorities shift when managing a patient in traction?
The overriding principle of traction is really simple. Continuous traction must be maintained.
Why is that so important?
It's essential to keep the bone aligned and to prevent painful muscle spasms. Releasing the traction, even for a second, compromises the alignment and must be avoided. Nurses have to ensure the ropes are running freely, the weights are hanging free, and the child's body is providing the counter traction.
We have a note here on post-amputation care. What's the immediate goal post-op?
Post-op stump elevation is allowed only for the first 24 hours to manage swelling. After that, continuous elevation is contraindicated because it drastically increases the risk of contractures in the joint above.
So what's the focus after 24 hours?
After 24 hours, the focus shifts to ensuring a full range of motion of the joint above the amputation. We also need to recognize the potential for phantom limb pain, which requires specific medication, sometimes amitriptyline, and other non-pharm therapies.
All right, let's focus entirely on the high-stakes emergency, compartment syndrome. How do we recognize it early?
Compartment syndrome is a limb-threatening surgical emergency. It results from increased pressure in a fascial compartment, which compromises circulation and nerve function.
And while all 5 Ps can be present, what are the classic early warning signs?
The classic early signs are severe pain unrelieved by analgesics that is completely out of proportion to the injury and paresthesia, so unrelieved tingling or numbness.
What's the classic trap with this?
The classic trap is assuming that a present distal pulse rules it out. Pulses may remain present until the condition is very, very late.
So if you see those early signs,
If you see those early signs, the immediate priority is to notify the provider, Elevate the extremity no higher than the heart to maintain arterial perfusion and prepare for a fasciotomy.
And that classic traction management trap regarding Bryant traction.
The Bryant traction trap tests your knowledge of countertraction. For Bryant traction to work correctly, the child's buttocks must be slightly elevated off the bed.
And if they're not?
If the nurse finds the buttocks resting flat on the bed, the traction is failing. They have to immediately reassess the weight and the position.
Regarding immobility, what are some of the subtle physiological traps?
One trap is assuming intervention solves it all. We have to focus on preventative measures. Routine incentive spirometry for respiratory health and aggressive fluid and fiber for GI health.
In the calcium issue?
Right. Another point to clarify. Bone demineralization causes a loss of calcium from the bones, leading to osteoporosis, not an increase in bone calcium. And finally, remember that neurovascular checks for an acute cast or traction have to be done every 2 hours, not every 4.
For fractures and casts, pain and swelling control are the immediate priorities.
Right. Analgesics, often starting with NSAIDs or progressing to opioids if it's severe. Non-pharm management. Immediate elevation of the extremity on pillows to promote venous return and reduce swelling. This is the immediate priority action if you see edema post-casting.
And cast care teaching.
It's vital. Keep it dry, watch for foul odors, and monitor the 5 Ps.
Managing generalized immobility requires a multi-system approach.
The non-pharm interventions are constant. Repositioning every 2 to 3 hours, using the incentive spirometer. Dietary management is key. Increase fiber and fluids to prevent constipation, and potentially adding supplements if hypercalcemia from bone demineralization is a concern.
And the number one action for an edematous casted leg.
The nursing action is always immediate elevation of that extremity above heart level to maximize venous return.
Okay, final recap for our last cluster. Mechanism: acute injury, growth plate involvement, and the consequences of prolonged immobility.
All marks. The 5 Ps, especially unrelieved pain and paresthesia for compartment syndrome. Evidence of abuse like inconsistent stories or multiple healing stages.
Rise flags.
Unrelieved pain after casting, the buttocks resting on the bed in Bryant traction, or any neurovascular changes.
In priority action.
Maintain continuous traction, immobilize the joints above and below the fracture, and perform frequent neurovascular checks every 2 hours.
And the NCLEX traps to avoid.
Misunderstanding the continuous nature of traction or delaying the reporting of those early signs of compartment syndrome. We have covered a huge swath of critical pediatric musculoskeletal concepts. And to synthesize, I think you just have to remember that knowledge of pediatric differences is paramount. Children heal fast, but they're uniquely vulnerable at the growth plate, and their entire developmental trajectory is threatened by immobility and these complex long-term conditions.
And we identified 4 essential safety checkpoints that really cut across all of these conditions, from DDH to a simple cast.
Right. First, the absolute priority of skin integrity with any external device harness, brace, or cast. It requires meticulous checks and avoiding lotions and powders. Second, the urgency of recognizing compartment syndrome, that severe, unrelenting pain and paresthesia are your early alarms. They demand immediate action. Third, the need for proactive care against immobility complications, especially supporting respiratory expansion with spirometry and aggressive GI management with fiber and fluids. And finally, understanding that structural issues like DDH, clubfoot, and scoliosis require years of family compliance and support.
That brings us to our final provocative thought for you, the learner. Considering the rapid, complex physical changes that accompany growth and the severity of interventions like spinal fusion or SEFE pinning, how does the potential need for major surgical intervention and the subsequent body changes or movement limitations impact the psychosocial development and body image of an adolescent patient? Think about the complex emotional support and the long-term adjustment teaching that becomes your primary nursing role in chronic musculoskeletal care.